What is up, guys? It's Stephanie again. It's driving time again. This is my part 2 of my protocol video, and in this video I'm going to try and break it down as to what the protocol is when we are looking at treating a patient. As always, this is while I'm driving. I am doing it hands-free. Got my little cell phone mounty thingy there. And I will be looking at the camera when I am able to look at the camera. I'm not going to be looking at the camera if it's not safe. Like, no, it is safe. No, it's not. No, it is. No, it's not. Alright, so previous video we covered the 4 H's: history, hazard, hello, and help. I will try and put the link up for that video in the comments or description of this video. I'll see where I can fit it. Ooh, that's a beautiful motorbike. Today we are going to be doing the rest of the protocol after the 4 H's. As I explained the protocol in the previous video, the protocol is running from letter A to letter J. And the protocol applies broadly to all first aiders and medics. There's some deviations which I will try and explain to you guys while I am at that point. So your first letter A. This is after we've made sure it's safe. We've already established the patient's consciousness level. We have already gotten consent. So A stands for airway. A, airway. Now, if the patient's conscious and they are talking, their airway should be what we consider as self-maintained. The airway should be open and they should be able to breathe because they are talking. The only risk here is if your patient may suffer from an allergy and starts, their throat starts swelling shut. That is going to be an issue under A. Right. If your patient is unconscious, we want to open the airway. Now there's 2 methods of doing this. Method 1, we look at if there is no suspected neck or spinal injury. If you are confident that there's no suspected neck or back injury, we can do what we call a head tilt chin lift method. This is where we place the palm of our one hand on the patient's forehead, these two fingers under the patient's, the other hands are the 2 fingers under the patient's chin, and we push their head backwards. That opens up the windpipe, aka trachea, and should in theory allow the patient to breathe easier. But here comes the problem. What if there was something in the patient's mouth and we tilt their head back? Because this is what a lot of people actually forget. If I'm opening the airway and there was something in the patient's mouth, I am increasing the risk of that thing rolling back into the throat, and then it's going to just become a pain in my backside. Alright, because now we've got to try and remove it. So what we'll do before we do the head tilt chin lift is I'm going to, obviously with gloved hands, guys, because that's part of the hazard is body fluid. I'm going to open the patient's mouth. I'm going to check in the patient's mouth if there is anything. If there is anything in there, I'm going to do what we call a finger sweep, where we use these 2 fingers, we scoop whatever we can out of the mouth. Alright, please just make sure that when you do the scoop, the finger sweep, that you are doing it in such a way that you're not actually pushing the stuff, the item or whatever's in the patient's mouth deep into the throat. Only do it if it is safe. Alright. So check mouth, finger sweep, head tilt, chin lift. If I do suspect, however, that there is a possibility of a neck or back injury, then I'm going to have to do what we call a jaw thrust maneuver or method. This is where I'm going to dislocate the patient's jaw. Now for that, I'm going to sit on my knees above the patient's head, and I'm going to be pushing from obviously the top, pushing down on the patient's jaw, down towards the feet, and then forward, down and forward. Right. That, if you do it nicely, will dislocate the patient's jaw and will, to a certain extent, open the airway then for breathing as well. Hallelujah, the traffic is starting to move again, above 10 km an hour. I hate traffic, but I love driving. So that's A, airway. Okay. B stands for breathing. Here we're going to assess the patient's breathing to determine whether they are or are not breathing. To do this, you can do what we call a look, listen and feel method. Patients lying flat on their back, aka supine. You're going to place your ear by the patient's nose, your cheek over the patient's mouth, and you're going to be looking towards the chest. So you are listening, feeling any air movements, and looking for any chest movements. There's a bit of a risk here, especially during / post-COVID, because now you are sort of in contact with the patient's breath. Now I'm going to be discussing the CPR protocol with you guys, and I'm going to be touching the COVID protocol as well during a following video, so please keep your eye out for that video. Then I'll discuss what you can do if there is a risk of the COVID, the patient having COVID. So the look, listen and feel I'm doing for 10 seconds. I'm not going to at this point bother counting the breaths or anything to that extent. I just want to determine whether the patient is breathing. C stands for circulation. Circulation is the big word for the blood flow, and to check the blood flow we look for a pulse, and during this part we are going to be feeling for the carotid pulse, the carotid artery. Now that is directly next to your windpipe. If you put your finger here, almost up in your under my beard, you'll find a little soft spot. If you put these two fingers there for 10 seconds, you should be able to feel a pulse. If not, just feel around a tiny bit, but it's right next to your windpipe in that soft area, sort of between this muscle here on the side and the windpipe, almost at the top where you'll find the pulse. Again, that's called the carotid artery, so you can have a look for it there. Always remember, we feel for pulse with index and middle finger, never the thumb, because our own thumbs has got a pulse of its own. So we're not going to stress about that. Might confuse you. So please don't do that. These two fingers. Again, we're going to do this for 10 seconds. And for breathing and pulse, I'll explain to you guys during a following video when we discuss the vital signs, why we do it for 10 seconds. Cool. So A, B, C, D. When we look at the first aid, UD stands for does the patient bleed? And I'm not talking about small paper cut, guys. I'm talking about like major bleeding, severe bleeding. When we look at does the patient bleed, I'm looking at like a massive cuts, amputation, anything to that extent. And the reason why I've put D as does the patient bleed is if the patient does need CPR, okay, And I'm going to be pumping on the chest. Pumping on the chest means I'm pumping on the heart. Pumping on the heart means I'm pumping the blood, circulating the blood through the body. And if this patient's got major bleeding already, and I'm pumping this poor dude's heart, or lady's heart, that may result in more blood escaping the body, which, I mean, it's not really what we want. So I'm going to get the bleeding. If there is major bleeding, I'm going to get it under control. I'm not going to spend 25 minutes treating it. I just want to get the bleeding under control, be it a direct pressure or indirect pressure, or asking one of my colleagues to quickly put on a pressure pad. And oh, another nice bike. Just get the bleeding under control quickly. Alright. E, when we're looking at first aid, is effect CPR. Start with CPR. Now CPR will only be provided, and like I said, I'll do a video for you guys on CPR as well. CPR will only be provided if there's no breathing and no pulse. No breathing, no pulse equals CPR. Alright. If there is a pulse but no breathing, we're going to do what we call artificial respiration, which I will discuss with you guys in a following video. Cool. So E effects CPR. When we're looking at a bit more medic perspective, D can stand for defibrillate. This, even first aiders that has done your AED training, if your training institution has covered AED, then you can just get your defibrillator, and if there's no breathing impulse, put on the defibrillator, press the button, let it analyze, and see what it says. Right, guys, please get training on an AED. You can go on BLS training, basic life support training, through a registered American Heart Association instructor. The AEDs are fantastic little machines. It is a bit expensive, but it's reusable except for the pads, and it really does make a massive difference. Okay, so E effect CPR. We've chatted about that. Now we get two different types of what we call examinations. You get your primary examination and you get your secondary. Airway, breathing, circulation. Does a patient have severe bleeding? Falls under your primary examination. That is the first thing that you want to do. Okay, we're not going to spend time while the patient is not breathing on treating paper cuts. We want to get the main stuff done first, because no breathing, no pulse, severe bleeding, all of that can kill your patient a lot faster than a paper cut. Right. Your secondary is F and G, and then we've got H, I and J after that. Okay, so F stands for fractures. Now, if your patient is conscious and speaking, do I need to check for airway, breathing and circulation under your primary? No. What we'll do in that case, if your patient is conscious, we will assess the vital signs. Okay, but I'll explain that to you guys just now as well. If your patient is unconscious and they are breathing and they do have a pulse, I don't need to do CPR. I can do a head-to-toe examination, starting at the top, working my way all the way. Sorry guys, I have not had my first coffee. Coffee contains caffeine. Caffeine is king. Start from the top, go the way down. Now, to do this examination, there's a couple of stuff that you have to consider. We don't want to miss any area. So to do this, everywhere where we examine, we're going to do flat-handed sliding motions. Going to take your hand, okay, let me do it like this. You take your hand, you're going to put it down, you're going to slide it along the arm. If you do this, you might miss injuries along the way. Right, flat sliding motion. Make sure you examine everywhere. You're feeling for any sort of weird lumps, bumps, dips, divots, wetness, anything to that extent where it's abnormal. Okay, and I'm back in traffic. Starting at the head. Okay, so that's the first one, flat sliding motions. Second part is when you get to the end of a limb, you want to ensure that there is good circulation to the extremities. Okay, so you're going to feel for pulse. I'll show you guys just now when I have opportunity, when traffic is stopped again, I'll show you where to feel a pulse on the arm. This is just to make sure that there is circulation to, like I said, the extremities. If there's no circulation, it means that you've missed something. So let's say there's no circulation at the wrist, you've missed something between here and there, because there has to be some blood flow, something causing the blood flow to stop to the wrist. Cool. Another thing with okay, if you guys are wondering why I'm so tired, I've got upcoming exams, so I've been studying and it's hard. The other thing that you've got to consider when you are looking at your head-to-toe examination is there's areas that you've got to avoid. All private areas you're going to avoid. Please do not examine the patient's breasts nor their groin area. And this is a topic that we've discussed at length. When you are examining the same gender as what you are, guys, with especially like anybody from America watching this, with the variations in the genders that there is currently, please don't assume your patient's gender. I mean, a couple of years ago, if I'm a male, I could examine a male's breasts. If I was a female, I could examine a female's breast. But now we can't assume a patient's gender anymore, so please avoid the breast and groin area at all costs. Okay, one thing you can do, however, is if you are examining a male, you can look at the groin area without exposing, without touching. You can look at the groin area to see if there's an erection. An erection, aka a priapism, could be very indicative, could be symptomatic of a spinal injury. That's a very, very good telltale sign that the person may have spinal injury. Okay, please don't touch. You can also look at the groin to see if they wet themselves. Wetting themselves could be a possible indication of pelvic injury or bladder or kidney injuries. Right. So that's the head-to-toe examination. Looking for F, fractures, or G, general injuries. General injuries like, I don't know, contusions, bruises, small lacerations with minor bleeding, small burn wounds, general injuries, general stuff that the patient will experience. After I've done, there's no suspected spinal injury, the patient is breathing, and there's a pulse. We're going to put the patient in the recovery position. On their side, we're going to cover the patient to maintain body temperature, and then we are going to monitor the patient every 4 minutes. Every 4 minutes I want to check for breathing impulse. And the reason why we say every 4 minutes is between 4 to 6 minutes with no oxygen supply, the body's tissue cells will start dying. So if I can catch within the first 4 minutes of no breathing, I can lower the risk of tissue death, cell death. Alright, so that's why I say 4 minutes, so we can, if there is no breathing, we can get the oxygen supply back up and sorted. Right, now H. So we've done F, G. H is handover. This is now when the ambulance or higher qualified person arrives, I'm going to hand the patient over to them. Now for the handover, we utilize an acronym called MIST, M-I-S-T, MIST. Now MIST stands for M, mechanism of injury. How did the patient get hurt? I, injury. What injuries have you found during your examination? This will include no breathing, no pulse, fractures, burns, whatever, soft tissue injuries. What injuries have you found? And T, what treatment have you or any other person given? Now, why do I say any other person? Because of this. A couple of years ago, I worked at a company. I was their medic. A young lady was sitting with abdominal pains, and the manager gave her 2 Disprins to drink to help her with the pains, but the condition, the pains got worse. Now, if we get to a point where you've got an advanced life support paramedic that arrives and he wants to administer morphine, because there was already pain killers, pain management medication given by somebody else, it may force the paramedic to re-look at what pain medication they give. Right, same with if the patient is asthmatic and somebody borrowed them their asthma pump, that may affect the treatment that the ambulance will give the patient. So what treatment has been rendered, and also how long ago was that treatment rendered. Do I say signs? Yeah, it's signs and symptoms. Mechanism of injury is signs and symptoms. Signs and symptoms again, how do I know what is wrong with the patient, or how do I make that determination? And then T, treatment. Okay, missed. So that's H, handover. Once you've done the handover, just ask the ambulance crew, are they happy? Can you go? And you can go if you don't want to stay and help. Okay, if you need a cup of coffee afterwards. I comes for infection control. This is where, if there's body fluids that was spilled, most regulation 7 first aid kits has got what we call a spillage kit in. You can use that spillage kit to actually decontaminate and disinfect the area. so that there's no risk of somebody else coming and slipping on the body fluids or getting infected by something from the body fluid. Okay, infection control. I always say to this, most companies have got cleaners. Please guys, do not let your cleaners clean up the body fluids after you treated the patient. Most cleaners have not received any first aid treatment. They are not aware of the risks. Please just get the thing clean, get the area clean, and discard of your medical waste appropriately. If you can do it, because what happens a lot of time, the ambulance will load the patient into the back of the ambo, and then they're going to quickly do their paperwork. So you've got maybe about 5 minutes or so, in most cases, where you can quickly clean up the area, and then you can ask the ambulance, can I please put this contaminated paper towel in a bag in your medical waste box? 99% of the time the ambulance will be quite cool and say, okay, it's fine, don't stress, put it in. Right, so that's infection control. And then J stands for JOCO. JOCO being the T. This is after you've now done the treatment, after you've done your reporting, after you've done everything, and you can now go and sit and relax and enjoy a cup of tea and de-stress and de-stress yourself a bit from the stress now of treating the patient. Anyway guys, sorry, it's another almost half an hour video. I hope it helps. I'll carry on with these videos. If there's any more contents or suggestions that you guys would like to see, please smash into the comments. And as everybody on YouTube says, please like, share, subscribe to this video, smash the bell icon so you can get notifications of upcoming videos. And yeah, any questions, concerns, throw it into the comments and I can see where I can help you guys. Cool, have a good one.